Hello, I'm Rafat Abonour. I'm the Harry and Edith Gladstein Professor of Cancer Research at Indiana University. I'm honored to present to you the American perspective, addressing the question whether randomized clinical trials findings help real-world newly diagnosed multiple myeloma patients. This is a slide of my conflict of interest, including research support and advisory for an area. Randomized controlled trials conducted with several novel therapies have shown significant improvements in long-term survival and led to the approval of many new drugs and new combinations. However, there are challenges associated with translating the outcomes from randomized clinical trials to real-world patients. Patient outside clinical trials can be different due to patients' comorbidity, toxicity burden, and other factors such as access to drugs and supportive care. The participation in clinical trials in the USA is very low, less than 10%, making it difficult to generalize finding from clinical trials to the majority of patients. Barrier to participation in clinical trials varies by region and by access to care. There are patient-specific barriers, such as the lack of interest or lack of information, concern about the commitment to clinical trials, myth about clinical trials like being on placebo versus active drugs. There are protocol-specific barriers, such as the eligibility criteria, time demands, and availability in a number of prior line of therapies. And also, there are physician-specific biases. The stringent inclusion and exclusion criteria, which are intended to reduce heterogeneity in the study population to ensure consistency in treatment effect and to protect patient safety. And the inclusion and exclusion criteria are generally consistent between trials, but have evolved empirically over time without supportive data. So we published a few years ago analysis on common eligibility criteria of randomized controlled trials in newly diagnosed myeloma patients, and we tried to look at the outcome of these patients. This work is part of the CONNECT-MM registry and was sponsored by Celgene. So we looked at 24 randomized clinical trials and evaluated those trials where thalidomide, lenalidomide, and bortezomib were used in the newly diagnosed patients. The most common randomized controlled trials include exclusion criteria, where absence of measurable disease, peripheral neuropathy grade more than 2, poor performance status was an ECOG score of 3 or 4, history of myelodysplastic syndrome, other hematologic malignancy, or solid tumors. We did not look at age in this group because of huge variability among these 24 trials. We were able to identify 1,406 patients who met CRAB criteria in the first cohort of the CONNECT-MM, were enrolled between 2009 and 2011. 563 patients, or 40% of the patients, were considered ineligible for randomized controlled trials on the basis of M protein less than 1 gram per deciliter, hemoglobin less than 8 grams, or advanced kidney dysfunction with a creatinine above 2.5 milligram per deciliter. When we look at the hemoglobin, 44% of the patients were ineligible. If you combine the hemoglobin with low M protein, 56.8% of the patients were ineligible for these trials. Renal dysfunction excluded only 14% of the patient. If you look at the characteristic of patients who are eligible or versus ineligible to randomized controlled trials, ineligible patients were significantly sicker with advanced disease, more hypercalcemia, more renal failure, more anemia, and more stage 3 disease. If you look at therapy offered to ineligible versus eligible patients, there were more patients in the eligible arm received lenalidomide and transplant. overall survival was superior in that randomized clinical trial eligible patients, 70% versus 63%. However, the difference was not there when the patients offered transplant. And there is narrowing of the difference when patients were offered novel therapy or triplet in their treatment. For example, if patient get a novel induction therapy, the 3-year survival was 63% versus the eligible patient was 77%. If patient received a triplet, the ineligible patients had 69% 3-year survival versus 74% in transplant in randomized clinical trial eligible patients. In this graph, what you can see that the transplant benefited both eligible and ineligible patient to randomized controlled trial. Similarly here, this graph showed you that novel combination with transplant improve the outcome of both group of patients. Poor performance status and low platelet counts were the significant risk of death, as you can see on this table. However, for example, the hemoglobin was not a factor. In terms of serious adverse events, according to randomized controlled trials, eligibility and predictor of side effects, with the exception of hemoglobin less than 8 grams, all factors remain significant in multivariate analysis and are considered to be independent risk factor to developing serious adverse events, as seen in this table. So we updated our data to include all patients who enrolled on the CONNECT-MM registry, and we also looked at the baseline quality of life and the change over 1 and 2 years after treatment. So we were able to analyze 1,622 patients who were eligible for randomized controlled trials. That's 56.5% of the group, versus 1,251 patients who were ineligible, or 43.5%. The data cutoff was January 7, 2019. And in the eligible patients, there were more patients older than 75. There were more patients with poor performance status, such as ECOG performance status 3 and 4. More patients have unmeasurable disease. Fewer received transplant, 34.5% versus 42.8%. And maybe fewer receive a triplet with lenalidomide, bortezomib, dexamethasone as an initial therapy, 23.9% versus 31%. The use of maintenance therapy in this registry was low, with 18.1% in the ineligible patient and 22.7% in the eligible patients. When we look at the quality of life, in the eligible patient has significantly higher absolute baseline quality of life scores for FACT-MM, trial outcome index, and for FACT-MM subclass. However, both groups demonstrated significant improvement in quality of life from baseline at 1 and 2 years. Patients who are ineligible for clinical trials did have shorter PFS and overall survivals versus eligible patients. As you can see here, the median PFS was 27.8 months versus 31.8 months, and overall survival was 63.1 versus 71.3 months. So my conclusion is that this analysis showed that a substantial portion of patients with newly diagnosed multiple myeloma in the CONNECT-MM registry, about 44%, would be ineligible to participate in trial-based setting using common randomized controlled trial eligibility criteria. Results suggest that these patients have more comorbidities, advanced stage disease, and lower overall survival rates. However, with novel therapy, both the outcome and quality of life improves for randomized controlled trial in eligible patients. So reevaluation of randomized clinical trial eligibility criteria is needed to improve enrollment without compromising the ability of trials to determine treatment effects. Otherwise, further advances in treatment will continue to be on the basis of small, select patient population that does not reflect the real-world multiple myeloma patients. We are grateful to the patient for volunteering to provide their data and information about their quality of life, to Celgene, now BMS, and to my co-investigator. Thank you.